Let's decipher the CBC. Here's your basic CBC. Basically, you're looking at the white blood cells, the red blood cells, H&H, and the platelets. Here's your CBC with dip. Now notice with the differential, you get all the different types of white blood cells broken down. So if you're concerned in a patient about infection or inflammation or bone marrow etiology, the differential can be helpful. But if you're just working up anemia or platelets, there's no reason to add on the diff. It just adds cost to the patient. There's several things that can cause a drop in white blood cell count. Basically, think infection, inflammation, and autoimmune disease. Now, let's start with infection and inflammation. Usually, when we think of those things, we think of a rise in white blood cells. And that's generally what happens, except in the early and very late stages. Most of our white blood cells that we're checking on the CBC is neutrophils. Neutrophils are the largest component of the white blood cell, and they're reserved in the bone marrow. So when you order your CBC on a patient, you're checking the few that are actually in the blood. So early on in an infection, these early responders, these first responders, are going to be dying off in the battle. The reserves from the bone marrow have not arrived yet, so the white blood cell count will be low. Then after a few days, the reserves come and the white blood cell count elevates. Also in chronic infection, late stage ongoing infection, there's going to be a disruption of the production of white blood cells within the bone marrow, so the count is low. Same with cancer. Late stage leukemia, the bone marrow has just given up. Your late stage leukemia, the outlook is not good. The bone marrow is pooped out. And so you see this drop in the white blood cell count. Certain medications, Wellbutrin, Lamictal, obviously chemo. So your workup, if the etiology is not evident, your workup should include a head-to-toe exam and a medication review. Pay special attention to the lymph nodes, because you can see this with lymphoma, you can see this with leukemia. Evaluate for joint pain, because you can see leukopenia with autoimmune diseases. Maybe evaluate for a rash, for a connective tissue disease. Paresthesia would be another thing to look for, because a low B12 can cause leukopenia. Now again, that would be late stage, chronic, ongoing. If the patient has no signs, no symptoms, the patient is stable, then it's okay to monitor. If there's a stability in the white blood cell count, even though it's a little bit low, the patient feels great, every 3 to 6 months, just keep an eye on it. Make sure it's not further deteriorating. If it is further deteriorating, another workup needs to be performed. Maybe get a specialist involved too. And then here are several things that can result in an elevation of the white count. Obviously, infection. That's the body's natural response to an antigen. Leukemia, as long as it's not late stage, the bone marrow will be cranking up production of white blood cells to insane amounts. We'll do a case study on one of my patients. White count was 79,000. You can get insane levels. Cigarette smoking. There's a mild inflammatory response when our patients smoke cigarettes. I want to talk here too about the peripheral blood smear. I don't have a slide on it, but whenever you have unexplained leukocytosis, in some cases leukopenia, if you're concerned something's going on and you can't figure it out, unexplained anemia or thrombocytopenia, order a peripheral blood smear. With a peripheral blood smear, it's a microscopy exam to look at the morphology of the cells. So generally a pathologist or a trained technician will do this. But they're just looking for weird cells. So with a leukemia, oftentimes there will be blast cells, which are immature. That's not normal. It's not normal to have immature blast cells in our blood. They'll be looking for smudge cells. Smudge cells are lymphocytes they appear flattened and they get smudged. They're very fragile. So you're just kind of getting more information from the peripheral blood smear. And it's a good idea to perform it anytime with the CBC where you're just not sure what's going on. The etiology is not clear. It's a good tool to remember that you have. Neutrophils are the first responders to the infection site. Now, the majority of white blood cells are neutrophils, so causes for low and high neutrophils are generally the same as leukopenia and leukocytosis. But a very important rule to remember, not just for this upcoming test, but for your clinical profession, is the left shift rule. An elevation in neutrophils is generally indicative of a bacterial infection. There's two phases of neutrophil release. So let's say your patient has a bacterial infection. Between 0 and 20 hours after the onset, the consumption of neutrophils for that bacterial infection at the site of the infection exceeds the bone marrow's ability to produce replacements. But after the first day, the bone marrow releases all the neutrophils, the reserves are there, and you see that elevation. So the first day, the neutrophil count can be low to normal. But after that first day, it will shoot way up. Now, back in the day when lab technicians counted the different cells by hand, the theory is, the story, that the neutrophil count was on the left side. So the technician would be flicking the calculator like crazy on the left side because of all the neutrophils. That's where the term left shift came from. But it's very important to remember that if you see an elevation in neutrophils, by and large, you're looking at a bacterial infection. So if you're like, is this viral? Is this bacterial? I really can't tell. Well, CBC with diff can be a great indication. If there's a left shift, kind of steers you more toward a bacterial infection. What about lymphocytes? The thing I want to focus on this slide is lymphocytes are usually elevated during a viral infection, such as mononucleosis. So you see that patient, he's got 3 weeks of whatever, you're like, but there's just no overt signs of bacterial infection. Order a CBC with diff. Lymphocytes are elevated, you're probably dealing with a viral infection. Neutrophils are elevated, you're probably dealing with bacterial. Now that doesn't mean you have to order this on every single patient with an infection, but it's just a nice tool to have if the etiology is unclear. Monocytes, they engulf and digest the antigens and the dead cells. They play a huge role in sounding the alarm when there's an infection. They trigger the immune response. They recruit lymphocytes to the site of infection. Low is generally not too worrisome as long as all the other types of white blood cells aren't low. If all the other white blood cells, the entire CBC looks normal except the monocytes are a little bit low, generally we don't do a whole lot. Now, if all the white blood cells are low and there's overall leukopenia, you got to be thinking either early leukemia or late stage leukemia. But if those are all normal except for the monocytes, generally not too much of a concern. High, you'll see that in chronic infections, autoimmune disease, and then a type of leukemia. Now, generally with leukemia, you'll see all the white blood cells elevated, especially just the overall white count. The monocytes are pretty cool. They live for years. They just kind of float around doing their thing. Eosinophils are involved in our allergic or inflammatory response. They also are activated when we have a parasitic infection. Again, low, as long as it's just the eosinophil, it's not too significant, it's not too concerning. High, well, you're thinking those diseases and illnesses that are associated with an IgE response. Allergies, asthma, can see it in celiac, but usually those IgE and parasite infections. So when you think allergies, asthma, and parasites, think eosinophil count. And that first picture on the right is an eosinophil. The one on the bottom is a basophil. Not too much to go over on basophils. Okay, you see a patient has thrombocytopenia, low platelet count. Number one, is that patient pregnant? Number two, how is the patient's hepatic function? Thrombopoietin is made in the liver. Going along with that is alcohol intake. Is there a long-standing viral infection like HIV, hepatitis? Hepatitis, you'll see an elevated AST and ALT. Epstein-Barr virus, which is mono. You'll be fatigued, have posterior cervical lymphadenopathy, and an elevated lymphocyte count. Do the workup for underlying cancer. Get a peripheral blood smear. And in certain situations, if you're concerned, do an autoimmune workup. So, number one thing you need to do, is the low platelet count severe? If it's less than 50,000, there is something significantly wrong going on. You need to get hematology involved. But if the patient is stable and the platelet count is not severe, get a peripheral blood smear, get a CBC with diff, get a hepatic function. If all of those are normal and the patient feels great, it is okay to monitor the platelet count. There's such a thing as immune thrombocytopenia, where they just walk around with a low platelet count. If the patient is stable and the platelet count is staying steady wherever it is, as long as it's not under 50,000, just monitor it. But if you have any concerns for anything else going on, or the platelet count is steadily declining, get hematology involved. But otherwise, it's okay to just kind of monitor that. Okay, red blood cells carry oxygen throughout the body. Elevated red blood cell count, think, is there an underlying condition that makes it harder for the body to obtain oxygen? The body has to work harder to get that oxygen. Well, what would cause that? Heart disease, an obstructive lung disease like COPD, sleep apnea, smoking, living at high elevations. The patient lives at 7,000 feet in Colorado. Everybody out there. When I was stationed in Colorado, everybody has a high red cell count. Right? You're living at 7,000 feet. We're going to talk about polycythemia vera. I think it's the next slide. We'll talk about how to work up anemia, which is when the red count is low. Let's define a few things. Hemoglobin, grams per liter of blood. So it's just how much hemoglobin is in the blood. And then hematocrit is how much of the blood consists of red blood cells. So hematocrit is a percentage. It's just a further indication of the amount of hemoglobin within the body. When you evaluate an elevated red blood cell count, generally you can pinpoint an underlying etiology. Let's say the patient has COPD. There's going to be some signs and symptoms. Let's say the patient has sleep apnea. Obviously, if they smoke, hopefully they're forthcoming with that. If they have heart disease, there's going to be signs and symptoms. Unlike the white blood cell count, where sometimes leukemia, the first sign is on the white count. Same with platelets. So that makes it a little bit easier to work up an elevated red blood cell count. But another thing to keep in mind is an incredibly rare cancer known as polycythemia vera. It's a slow-growing cancer in the bone marrow where there's an elevated red blood cell count. The most common finding is aquatic itching. And that's generally in warm water. So the patient gets in the shower and just itches like crazy. That's the number one sign of this cancer. The mechanism of action is unknown. there's an increased risk for microvascular symptoms, like paresthesias and headaches. So I guess the take-home point on this slide is this is a very, very rare cancer. If you see an elevated red count, evaluate for pulmonary etiology, cardiac etiology. But keep this in the back of your mind. Number one symptom, aquatic itching. You can see the work up there. Don't memorize that for testing or anything like that. It's just something to remember that's out there. All right, let's further interpret our CBC. So the MCV, the mean corpuscular volume, is the average size of the red blood cells. What's the difference between the MCH and the MCHC? Well, number one, you will probably never use the MCH because the MCHC is so much more informative. The mean corpuscular hemoglobin, the MCH, is the average hemoglobin content within all of the red blood cells. But the MCHC is the average hemoglobin concentration per red blood cell. So the MCHC takes the size of the red blood cell into account. In other words, how much hemoglobin does the average red blood cell have based on how large the average red blood cell is? So the MCHC, much more informative than the MCH. So if you see a patient who has a low red blood cell count and a low H&H, hemoglobin hematocrit, generally the next two things you're going to look at are the MCV and the MCHC. You don't even need to bother with the MCH. The red cell distribution is just the variance of the sizes of the red blood cells. So if there's an elevated distribution, there's going to be a lot of different sizes. If there's a low distribution, they're all going to be mostly the same size. Okay, so you have a patient, you do a CBC on him or her, there's a low red blood cell count, there's a low hemoglobin, and there's a low hematocrit. The patient has anemia. Then look at the MCV and the MCHC. A macrocytic MCV is going to be an elevated MCV. The red blood cells are larger than average. Normocytic is their normal size, and microcytic anemia is a low MCV. The red blood cells on average are smaller. Then look at the MCHC. How concentrated is the red blood cell with hemoglobin? So if it's hyperchromic, if the MCHC is elevated, it's going to be very, very red. It's going to be packed full with hemoglobin. Normocytic is just normal, and hypochromic is going to be pale in color. There's not much hemoglobin in the average red blood cell. So when you diagnose a patient with anemia, you have to diagnose the type of anemia. Generally, macrocytic goes hand in hand with hyperchromic. Microcytic goes hand in hand with hypochromic. So we need to determine, well, what are the underlying causes of microcytic hypochromic anemia, and what are the underlying causes of the other two? Well, first off, is this severe or not? What do you need to do with it? Generally, a hemoglobin that's less than 7 needs a transfusion, so you need to admit these patients. If it's over 7, play it by ear, but generally they don't need a transfusion and you can treat them outpatient. But again, that's not a definitive rule. It's an individualized treatment. Okay, if you're going to go family practice, you're probably going to see microcytic hypochromic anemia within the first week. Very common. The number one cause is iron deficiency. Thalassemia and lead poisoning can also result with microcytic hypochromic anemia. We're going to go over each of these. This is just an overall slide. Normocytic, normochromic anemia generally is not good. That is not a good diagnosis. Generally, it's due to malignancy, severe renal impairment. You can see it with hemolytic anemia. Generally, if you see that, it's like, oh no. Macrocytic hyperchromic anemia usually is going to be B12 or folate deficiency. There's a few other things like copper deficiency, you can see it, but generally it's B12 or folate. So on the exam, you'll want to look for angular cheilitis. Angular cheilitis is that first picture on the left, the cracks beside the mouth. Now there can be a plethora of causes. One of those causes can be low B12, but it can also be like a bacterial infection, like this guy on the picture. It looks like he has impetigo. It can be a fungal infection. There's a slew of causes, but one of which is low B12. Cardiac exam, you want to listen to murmurs. And then spoon nail. That's this last picture here. Spoon nail is a sign of iron deficiency. Kolonychia. So what are your patients who are at risk for anemia? Well, vegetarians who aren't getting enough iron. Patients who have a history of gastric surgery. The removal of the intestinal tissue results in decreased absorption of nutrients. Celiac sprue, there's a malabsorption going on, and so on. Patients, I should also have on here patients who are on chronic PPIs. Low B12, you got to check the B12 once a year on those patients. Okay, you have a patient who's deficient in iron. I'm going to say it is much more common in females. How will she present? Well, usually she'll come in and she'll be like, man, I am so tired. So any fatigue, weakness, tiredness needs to be worked out with the CBC. If the patient is deficient in iron, she will have microcytic hypochromic anemia. The MCV will be low and the MCHC will be low. You have some tools at your disposal here. Serum iron measures the iron in serum that's bound to transferrin. Transferrin is the protein that transports iron around the body. Now you can check a serum transferrin too. Ferritin is the protein that stores iron. Now most of that is within the liver. So the serum test is going to measure circulating levels. Generally, if you have a patient who has a microcytic hypochromic anemia, as part of that workup, you're going to order a serum iron and a serum ferritin. You might be like, but if I'm concerned about low iron, shouldn't I really look at the serum iron? Well, a menstrual bleed or something acute, the serum iron will be low. So the ferritin is a much better indicator of the iron levels. And because of that, the ferritin is the gold standard for diagnosis. If you have a patient whose ferritin level is less than 15, you can diagnose that patient with iron deficient anemia. Now, one caveat to that. Chronic inflammatory states, like say RA or lupus, will throw off the ferritin levels. So if the patient has an autoimmune disease or is in a chronic inflammatory state, say they have polymyalgia rheumatica, then order the transferrin and use the transferrin to diagnose iron deficient anemia. Otherwise, ferritin is pretty much your gold standard. Okay, so you saw your patient, she was complaining of fatigue, you ordered the CBC, you saw microcytic hypochromic anemia, you ordered the serum iron and serum ferritin, they were both low. The ferritin was under 15, you diagnosed her with iron deficient anemia. Is your workup done? No. Always ask yourself why. Why is this patient deficient in iron? Now that further workup can just include sitting down and chatting with the patient. The number one cause is usually just inadequate intake. Is the patient a vegetarian? Does the patient have heavy menstrual bleeds? There's some questions in the upper right there to ask. Now, if you ask those questions, the more negative answers, the increased risk of iron deficiency. So there's an inverse relationship. Does the patient have an underlying bleeding? Is the patient losing blood somewhere? So questions there, is the patient on an NSAID? Increasing the risk for a GI bleed. Is there a malabsorption going on? Does the patient have celiac? If the patient is 50 or up, you have to check the stool some way. You got to. Even if it's just a Hemocult card, do something. Because there's a significant increased risk for a GI bleed if the patient is 50 and up. Evaluate family history and evaluate a history of gastric surgery. So just to bring this all home, look at the patient's medication history. Basically, you're looking at anticoagulants and NSAIDs. In a female, evaluate the menstrual bleeding, evaluate the diet, evaluate for malabsorption like celiac, and always consider some sort of GI workup, even if it's just a Hemocult card. There's some providers I've worked with to do a Hemocult card on everybody. You can be 18 and you'll get a Hemocult card. That's fine. There's no risk to a Hemocult card except for getting some poop on your finger. So, I mean, you know, always be thinking, is there an underlying GI bleed? Each of the below patients has a red blood cell count of 3.8, hemoglobin 10.7, hematocrit 31.7, MCV 70, and MCHC of 27.2. All right, so a normal red blood cell count for a man is 4.7 to 6.1, for a woman is 4.2 to 5.4. Normal hemoglobin for a man is 14 to 17, woman 12 to 15. Normal hematocrit for a man is 41 to 50%, for a woman is 36 to 44%. Normal MCV is 80 to 100, and normal MCHC is 32 to 36. Both patients have iron deficiency anemia because they have microcytic hypochromic anemia and the ferritin is less than 15. Let's start with patient B, which is a little easier. She denies signs of underlying concerns such as GI cancer, IBD, Meckel's diverticulum, ulcer, celiac, H. pylori. Now, for a menstruating female, we always want to ask about the menstrual bleeds. Hers are not significantly heavy, it doesn't appear. Would you do any other workup for her? Well, you could always do a fecal occult blood test with anybody who has iron deficiency anemia. I don't think I would on her, at least not right off the bat. She's vegetarian, so let's counsel her on diet or get her in with a nutritionist and start her on oral iron, 325 ferrous sulfate every other day on an empty stomach with a glass of orange juice. Have her come back in 3 weeks, repeat the complete blood count, CBC. The benchmark is a 2 gram per deciliter increase in hemoglobin at 3 weeks. So if she does that and you see that increase, just keep doing what you're doing until her levels normalize, then discontinue. Now at that point, you could switch her to a multivitamin containing iron, or if she's changed her diet and incorporated adequate iron, just discontinue the ferrous sulfate. But let's say she comes back, there's no significant change in her hemoglobin or her hematocrit. Now what? Well, first off, is she taking her iron? Is she tolerating her iron? Make sure she's taking it on an empty stomach, preferably with some vitamin C. Make sure she's taking it several hours apart from any antacids, PPIs, or H2 blockers. If she is, we need to do a further workup. I would now ask her very specific questions regarding her menstrual cycle. Menorrhagia is either a loss of 80 milliliters or more of uterine blood or prolonged bleed over 7 days, or both. So specific questions like, Do you soak through one or more pads or tampons per hour for several hours in a row? Do you use 2 or more pads at a time? Do you change pads or tampons at night? Are your periods longer than 7 days? These questions can be helpful in identifying a need for workup for conditions like uterine fibroids, polycystic ovarian syndrome. We could always consider thyroid disorders, bleeding disorders. And at this point, it wouldn't hurt to perform a Hemocult card on her. The Hemocult card has a sensitivity of 89% and specificity of 93% for colon cancer. We would also ask her specific questions pertaining to celiac disease and H. pylori, and our threshold for ordering diagnostic studies for these at this point should be low. She should have them. Let's jump over to patient A. What do you do for this guy? He's 70 years old. At absolute minimum, he needs a Hemocult or some fecal occult blood test. However, even with a negative Hemocult, 7% of colon cancers can be missed. Because of this guy's age, I would strongly recommend you refer him for an EGD and colonoscopy. When you refer for imaging, looking for occult blood loss secondary to iron deficiency anemia, an EGD and colonoscopy is the recommendation from the American Gastroenterology Association. The reason being is upper GI cancers can manifest as iron deficiency anemia too. Now, when these are being performed, the gastroenterologist will likely assess for celiac and H. pylori at that time. If for some reason the patient isn't referred for a colonoscopy and EGD, maybe the patient just refuses, doesn't have insurance, for whatever reason, then lab studies for celiac and H. pylori should be performed. Let's say the EGD, colonoscopy, celiac, and H. pylori are all within normal limits. The patient is taking his iron as prescribed. We'll then monitor for that hemoglobin increase of 2 grams per deciliter benchmark. For patient B, the female, we could do that without any additional workup apart from questioning. But for this guy, we do not want to wait on the benchmark. He's at increased risk for underlying neoplasms and other etiologies. He needs further workup right from the onset. However, let's say the initial workup is negative, but he's still not meeting his benchmark. Well, small bowel cancer could be playing a role. Underlying bleeding disorders could be playing a role. So you really need to perform a full exam. Look for bruising. Ask him specific questions about family history. With a normal EGD and colonoscopy, the small bowel is generally not visualized. But if you alert the gastroenterologist that you are referring the elderly patient for workup of occult blood loss secondary to iron deficiency anemia, the gastroenterologist will often perform an extended upper endoscopy, a capsule endoscopy, or other screening modalities for small bowel cancer in that elderly patient. So take-home point here, assess the risk, assess family history. Patient B, probably don't have to do a whole lot. Just start the iron, watch for that benchmark. Patient A, well, ideally, right off the bat, that patient should be referred for a colonoscopy, EGD, and consideration of celiac and H. pylori. Okay, thalassemia is the second most common cause of microcytic hyperchromic anemia. Thalassemia is a defect in the gene that controls for the production of hemoglobin. Hemoglobin is composed of 2 proteins, alpha and beta. So alpha thalassemia, which is more common in the Southeast Asian patients, African patients, patients from the Middle East, is a defect in the alpha protein, where beta thalassemia is more common in people from the Mediterranean. Now you can see complications from thalassemia like splenomegaly because the spleen has to work harder to filter all these damaged red blood cells. But to diagnose, you will see a microcytic hyperchromic anemia. The iron studies should be normal, and then you would order a hemoglobin electrophoresis. A hemoglobin electrophoresis is just a serum test, and it's an analyzation of the hemoglobin. So let's take a step back. You order a CBC on a patient, it reveals microcytic hypochromic anemia. You order a ferritin and an iron, and they're normal. We'll then be thinking thalassemia, tack on serum hemoglobin electrophoresis. That would be your next step. If it's mild, generally the patient doesn't need anything. But if it's moderate to severe, meaning symptom-wise, you want to get hematology involved. Finally, we have lead poisoning. Lead poisoning can also present as microcytic hypochromic anemia. At risk, it's very rare these days, thankfully. People who live in older homes where there's lead-based paint, moonshine drinkers, and I'm not talking moonshine from Gatlinburg. I'm talking, you go out back to the still moonshine. Symptoms: abdominal pain, constipation, headache, but you will see a microcytic hypochromic anemia. So as part of your workup for these patients, number one, workup for iron deficiency, consider thalassemia, and just ask them, about the house they live in, the age of the house. I don't know if you have to ask them if they're drinking shine or not, but whatever, just keep it in the back of your mind. Lead poisoning, rare, but will present as microcytic hypochromic anemia. If there is concern, just order a serum blood test, and it will be elevated. Okay, normocytic normochromic anemia is generally not good. Let's see this patient on the right. This is the patient's CBC. The red blood cell is low, the H&H is low. The patient is anemic. Next thing you look at, MCV, normal. MCHC, normal. This patient has normocytic normochromic anemia. That is a bad finding. For these patients, think number one, acute blood loss. That should be obvious. I'm not talking hidden GI blood loss or heavy menstrual bleeds. I'm talking this patient was in a car accident and they come in to see you and they're a bloody mess. Number two, think renal disease. Now that would be severe renal disease. And number three, think cancer. There are also rare cases, say the patient is deficient in both iron and B12, or both iron and folate. That's severe malnourishment, but you would see normocytic normochromic. You can also see it in a patient who has G6PD deficiency and took a medication they shouldn't have taken, like Tylenol or Primaquine, and then they have hemolytic anemia. But again, there will be signs and symptoms of that. So the workup, generally for your patient who has normocytic normochromic anemia, is going to be a peripheral blood smear. You want to look and evaluate for underlying malignancy, a B12, a folate, and an iron and ferritin. Just for those rare cases where the patient is deficient in both. You'll want to look at the renal function, so order a CMP. And consider a protein electrophoresis. I have a whole slide on multiple myeloma, so I'm going to save most of it for that slide. But for multiple myeloma, the top sign is normocytic normochromic anemia. Then you get the bone pain, and then you get hypercalcemia. So hold on to that thought. We'll come back to that. But that is your workup right there. And then you need to get these patients into hematology because this is a very severe finding in most cases. And then I don't want to go too much into the weeds on multiple myeloma because it's outside the scope of this class, but please just keep in the back of your mind normocytic normochromic anemia with bone pain. That's your typical presentation for multiple myeloma. With that, we would do a protein electrophoresis, which is a blood test, and looking at the different types of proteins that are in the serum. Let's go to the next slide. Macrocytic hyperchromic anemia, the red blood cells are larger than average, and they are jam-packed with hemoglobin. Number one cause, hands down, is B12 or folate deficiency. And these are going to be people who just aren't consuming enough, people who are on long-term PPIs, your alcoholics, your celiac patients who just aren't absorbing B12, maybe patients who are on metformin for their diabetes, can have B12 deficiency. So for these patients, you want to evaluate the medications that they're taking. Check a serum B12, check a serum folate, check the hepatic function. Consider hypothyroidism. Copper deficiency, you're generally only going to see that in gastric bypass patients, but consider it in those select few. But generally, B12 and folate is your cause here. And these patients are anemic, so they come to you and just be like, man, I'm just so tired. I'm just so fatigued. Now, in your elderly patients, B12 deficiency can be a sign of cognitive decline. They can be confused, irritable, frustrated, angry. Generally, though, that's going to be your elderly patients who have B12. Otherwise, it's just tired. They're just tired. For B12 and folate deficiency, there are a few things to know. B12 and folate are water-soluble B vitamins, but the red blood cell needs these B vitamins to form. If there's an inadequate intake of B12 or folate, the patient is going to get anemic because there's going to be a decreased formation of red blood cells. One type of B12 deficiency is pernicious anemia. Pernicious anemia is B12 deficiency secondary to lack of intrinsic factor. Intrinsic factor is secreted by the parietal cells within the gut. It allows for B12 absorption. Patients who have pernicious anemia have an increased risk for gastric cancer. So that's going to play a role in the workup. Hold on to that thought. But your labs, the patient is going to be deficient in B12. And if they have folate deficiency, deficient in folate. Let's say either the B12 or the folate is borderline. The patient has macrocytic hyperchromic anemia, but they're kind of borderline in either the B12 or the folate. Then check the MMA, methylmalonic acid, and the homocysteine. And you see that at the bottom of your slide. What are those? Well, B12 is a cofactor in the conversion of MMA to a substance that enters the Krebs cycle. Without B12, MMA levels increase. So in folate deficiency, the MMA will be normal, where in B12 deficiency, the MMA levels will be increased. What about homocysteine? Both B12 and folate are needed to convert homocysteine. It's a non-essential amino acid. The homocysteine will be elevated in both B12 and folate deficiency. Do you need to order these? Not necessarily. If your serum B12 and serum folate are clear-cut deficient, you don't need to order these. But if they're borderline and you're like, is this true B12 or folate deficiency? Adding on a serum MMA and or a serum homocysteine can help you in your diagnosis. Some providers order these routinely. It's just not really needed in every case. In some cases, it's clear-cut B12 or folate deficiency, and adding on these labs just increases cost to the patient's bill. Only order them if you feel like you need them. Pancytopenia, everything's low. The bone marrow is pooped out, it has given up. That, as you can imagine, is cancer until proven otherwise. That you will want to get in with hematology. This 17-year-old female has complaints of sore throat, headache, and extreme fatigue. So notice on her CBC with differential, her lymphocyte count is quite elevated. This is an example of the typical presentation of mononucleosis. You see a 67-year-old patient who presents with months of fatigue, unintentional weight loss, night sweats, and just feeling crummy. He quit smoking 30 years ago. Frail man. This was my patient. He had leukemia. Last I saw him, he was doing fantastic. He was on chemo. He was doing really, really well. But that's exactly how he presented. He came to see me It was the second time I met him. The first time was for a full physical. I was like, Jeff, we need to do some just baseline labs. He's like, nah, let's wait on the labs. I was like, all right. Then I didn't see him again for, I don't know how long. It was within a year, but I don't know how long it was. And then that's exactly what he said. He's just like, I feel really bad. I have no energy. Did some labs. His white count was through the roof. I didn't even have to ask the lab to do a peripheral blood smear. They knew I'd want one, so they just did it. And that's leukemia. That right there is classic leukemia. But he was doing well last I saw him. He was depressed because of the leukemia, but otherwise doing pretty well. You see a patient who presents with 1 month of sneezing, itchy eyes, and nasal congestion. Now, in most cases, you wouldn't do a CBC in this case, but if you did, for the allergies, it would not be surprising to find an elevated eosinophil count. 70-year-old male complains of paresthesia and itching when he is in the shower. What is the number one sign of polycythemia vera? Itching in the shower, and you'll see an increased red blood cell count, and that's exactly what he has. He needs to see hemo. 59-year-old alcoholic who's been having paresthesia, CBC is below. So let's start with the white blood cell count. That looks fine. Red blood cell count is low. H&H is low, so he has anemia. Look at the MCV. It is elevated. Look at the MCHC. It is elevated. He has macrocytic hyperchromic anemia. So what would be your workup plan for this guy? It would involve a serum folate, a serum B12, hepatic panel, consider a TSH. Given that he's an alcoholic and he is symptomatic, this is more than likely low B12. Would you treat him with oral? Would you treat him with intramuscular? Lots of options. Either one is fine. Okay, that concludes our lecture on deciphering the CBC, one of the most commonly ordered labs. Shoot me any questions or concerns. Thanks, guys.